Hi students, today's topic is icterus and respiratory system. Icterus means what? Nothing but an jaundice. So what is the difference between jaundice and icterus? What we say icterus, it is an yellowish discoloration of the skin and mucous membrane which is due to increased amount of bilirubin. This is what we say. So icterus and jaundice, what is the difference? Icterus is a clinical sign. If you see a patient yellow, he is icteric but doesn't require that he is jaundiced. Jaundice is a laboratory diagnosis where you take the blood of the patient and which is showing increased bilirubin, it is called as jaundice. Hope you understand the difference between both. Now what are the common sites we look for the icterus? We look at the sclera, normal sclera. We look at the bulbar conjunctiva. We look at the tongue, oral cavity. Okay, so these are some of the common sites, and never examine the icterus and confirm it within a room or something. We need a proper sunlight exposure to confirm whether the patient is having an icterus. Some basic points. Now coming inside, as a pulmonologist point of view, if the patient is having icterus and coming to your clinic, as a pulmonologist, what are all the things which will run in my mind? This is what we are going to discuss. Number one, what will I think of if the patient is having icterus is anti-tuberculosis drugs. Suppose the patient having a scenario is a case of tuberculosis, he is taking drugs, anti-TB drugs. So what are the first 10 anti-TB drugs? Isoniazid, rifampicin, pyrazinamide and ethambutol, streptomycin. Okay. So in this, out of this, 3 drugs are hepatotoxic. Pyrazinamide, rifampicin, isoniazid. All the 3 are hepatotoxic. The hepatotoxic means they cause hepatitis. That is called as AKT induced hepatitis. TB drugs induced hepatitis. Because of hepatitis, what is happening? Their transaminases levels, ALT, AST levels are raised and the patient is present to you with icterus. So one patient of tuberculosis, he is presenting with icterus, who is an anti-TB drugs. My first differential diagnosis will be AKT induced hepatitis. Few MCQs. Most toxic hepatotoxic drug, most hepatotoxic anti-tuberculosis drug is what? Number 1, pyrazinamide. Number 2 is rifampicin, followed by that isoniazid. So the most is pyrazinamide, then rifam, then isoniazid. So remember this order. So if you want to stop one drug first, stop pyrazinamide. Okay, and reintroduce the drugs in same order. If you want to start an AKT, restart the AKT in the liver patients, in this hepatitis patient. Once the AST, ALT levels are settled, first start isoniazid, then rifampicin, then finally pyrazinamide. Hope you understand. Now coming to the next cause. Suppose if the patient is there, okay, he's a chronic smoker, he's having a big bulge here, and you're doing CT, you're finding a mass, okay, he's coming with icterus. What will you think of? Definitely I will think the patient has got metastatized. Okay, so the patient is having metastasis. So what are the common organs where the lung cancers can metastasize? It can metastasis to the adrenal, it can metastasis to the brain, it can metastasis to the liver and to the bones. Okay, so if there is a liver metastasis, what will happen? The patient will be having with jaundice. So meds, second differential. Third, suppose the patient is in long-standing COPD, long-standing ILD, long-standing bronchiectasis, and he is presenting to you with the jaundice. Okay, and additionally he is having a swelling of legs, pedal edema, ascites, jaundice, raised JVP. What will you think of? Definitely I will think this patient has developed right heart failure secondary to this lung pathology. What it is called as cor pulmonale, cor P. Okay, so cor P patient, because of the congestive hepatomegaly, they can develop jaundice. Are you understanding? So my third differential diagnosis will be cor P. Fourth, suppose the patient is having an very tuberculosis which is very disseminated, involving the liver or some big abdominal TB with the lymph node which is compressing over the bile duct. So all these can also present with jaundice, disseminated tuberculosis. So what I want to say, my friends, is that I am just giving you a lot of facts, but the thing is, you need an appropriate scenario. In a bronchiectasis patient, if you are thinking it is because of AKT-induced hepatitis, it is wrong. So please match the scenarios. A TB patient taking anti-TB drugs, having a jaundice, AKT-induced. If a lung cancer patient, chronic smoker presenting with jaundice, think of meds. Long-standing COPD, long-standing ILD, long-standing bronchiectasis, presenting with swelling of legs, ascites, JVP, along with the jaundice, cor P. Okay, and long-standing tuberculosis and very disseminated form with maybe an abdominal TB or a lymph node obstructing, disseminated TB. So scenarios are very important. Only with the scenarios you can correlate with the etiology and with the finding. Okay, hope you understand. Thank you.